This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2017, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Pediatric ARDS. Do we have a consensus?
Draeger thanks the AARC and Dr. Cheifetz for facilitating this webinar and discussing pediatric ARDS. As a provider of intensive care devices, we develop solutions to enable clinicians to improve the lives of their patients, and we are proud to sponsor this webinar. Draeger understands the key challenges that you face and design our products to help you meet and exceed the challenges of improving outcomes, reducing the cost of care, and achieving greater patient satisfaction. Draeger's comprehensive portfolio of products, including patient monitoring, ICU design, biomedical support service, and of course, critical care ventilation. Our flagship ventilator, the Avita Infinity V500 platform, offers a comprehensive array of features, including invasive and non-invasive ventilation, as well as oxygen therapy. Our other ventilation products in our portfolio include the Savina 300 for acute and subacute care, the Carina for non-invasive therapy, and the Oxylog 3000 Plus for transport. Draeger is the proud recipient of the 2017 Frost & Sullivan Product Leadership Award. We appreciate the steadfast support from our customers and market leaders. Thank you again for attending today's webinar on pediatric ARDS, and to Dr. Cheifetz and the AARC for bringing you this presentation. For more information about Draeger's products and solutions, please visit www.draeger.com.
Upon completion of this AARC webcast, participants will be able to review the Pediatric Acute Lung Injury Consensus Conference definition for pediatric ARDS, discuss recommended approaches to mechanical ventilation for PARDS, and explore the use of adjunct therapies in the management of PARDS. I am pleased to welcome Dr. Ira Cheifetz. Dr. Cheifetz is a professor of pediatrics and anesthesiology, the Chief Medical Officer for Children's Services, and Division Chief at Duke Children's Hospital. He is also the Associate Chief Medical Officer at Duke Hospital. Dr. Cheifetz is active with the AARC as a member of the Program Committee, a member of the Board of Medical Advisors, and the Medical Advisor for the Neonatal Pediatric Specialty Section. Dr. Cheifetz discloses that he is the Medical Advisor for Philips and Acaria. I disclose I am a paid employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Cheifetz, welcome to the program.
Great. Thank you, Shauna. It's my pleasure to be here today to present a session on pediatric ARDS, now more commonly referred to as PARDS. What we'll review today over the next 40 minutes or so is the definition of ARDS for children. We'll focus then on some guidelines specific to conventional ventilation related to how to most optimally manage our pediatric ARDS patients. We'll then discuss some gas exchange goals of what should be our targets of ventilation, spend a little bit of time on high-frequency oscillatory ventilation, and then start closing out with some remaining comments on adjunct approaches, including corticosteroids, nitric oxide, prone positioning, surfactant, and neuromuscular blockade, and then just a few remaining comments on ECMO and the potential role of ECMO. So a lot to cover, but hopefully we'll be able to do that in the allotted time and provide you with information that would be helpful in your everyday clinical practice. The first section will be the first 4 of these topics, starting out with the definition and then moving on from there. So if we go back just now 2 years, almost exactly 2 years ago, we have the PAARC definition of pediatric ARDS. PAARC was the Pediatric Acute Lung Injury and Consensus Conference, and this is the first attempt and the first definition we've had for pediatric ARDS. Prior to PAARC, and I will use that an acronym abbreviation throughout my presentation, prior to PAARC, we were always, as clinical clinicians in the pediatric realm, we were always reliant on adult-based definitions for acute respiratory distress syndrome. With PAARC, we now have pediatric-specific criteria, and those I will go through in the next couple slides. But I would reference here that most of my material, at least the material for the first several sections, all come from the Consensus Conference proceedings, which are published in the June issue of Pediatric Critical Care Medicine in 2015. So the definition for pediatric ARDS, first we're going to focus on the top of the slide, age. PAARC defined pediatric ARDS as to be those lung diseases that occur in childhood and infancy, but specifically to exclude those patients with perinatal-related lung disease. So there's not a lower age or gestational age limit, but we are excluding perinatal-related diseases such as diaphragmatic hernia, meconium aspiration, etc. The timing for pediatric ARDS is that it must occur, or the onset must be within 7 days of a known clinical insult, and the origin must be respiratory failure that is not fully explained by cardiac failure or fluid overload. Lastly, chest imaging, similar to it occurs in the adults, must be performed. However, in this case, we no longer require a chest X-ray. The imaging can be any modality, including CT scan, and the imaging must reveal a new infiltrate consistent with an acute pulmonary parenchymal disease. PAARC, for the first time compared to prior definitions, also includes those patients who are not intubated. So specifically for those patients who are on full face mask, non-invasive, bilevel ventilation, or CPAP with a CPAP pressure greater than 5 centimeters of water, as you see on the slide, there are specific definitions for defining pediatric ARDS. Lastly, in the bottom portion of this slide, we see the 3 different categories of PARDS, mild, moderate, and severe, based on either the oxygenation index, if the patient has an arterial line, or the oxygen saturation index for those patients who do not have arterial lines and thus do not have serial PaO2 measurements. What's notably missing from this slide, and this is consistent with the Berlin definition of adult ARDS, is the term acute lung injury. The term acute lung injury has been eliminated, and at this point we have really 4 categories. One I'm not going to discuss here today, and that's at risk for ARDS, and then we have mild, moderate, and severe pediatric ARDS. If we look at these 3 if we look at those 3 categories, mild ARDS in yellow, moderate in orange, and severe in red, these are the oxygenation index cutoffs shown on the prior slide. We see a very clear step up in mortality as we go from mild, moderate to severe PARDS. A little bit of a side comment, one of the discussions that have ensued from PLEAK is truly there is probably another category of patients with OIs much higher than 20 where mortality continues to rise, often viewed as the bone marrow stem cell transplant population and other high-risk populations. So hopefully there'll be more data, more information occurring on those super severe ARDS patients. Also important about PLEAK is that PLEAK looked at all populations and specifically focused on three special populations. Those with congenital cyanotic congenital heart disease, those with chronic lung disease, and lastly, those with left ventricular dysfunction. I'm not going to read the slide or the details of these three, but it's important to note that we now have specific definitions of ARDS for these three specialized categories of pediatric patients. And the key part here, especially of the first two, the congenital heart disease and the chronic lung disease, is it takes into consideration the patient's baseline saturation and looks for an acute change from baseline sats. As I move out of the definition of PARDS and move much more towards ventilatory support and the management of these critically ill patients, I'll reference this publication, which is in the supplement to the PLEAK work, looking at ventilatory support in children with PARDS. I had the privilege of co-authoring this paper with Peter Reimensberger out of Geneva, and I will share with you over the next few slides the consensus recommendations from PLEAK specifically to conventional ventilation. The first question, this is a question I very commonly get when I'm at ARC, other conferences and in other areas, is what mode of ventilation should we use? What's the right mode of ventilation for our patients with PARDS? And the answer is the mode that you're most comfortable with, the mode that makes sense physiologically, the mode that your unit frequently uses, because there are absolutely no outcome data that say that there's any influence of mode. Stated the other way, mode has ever been shown to affect outcome for any disease entity in pediatrics, but specifically to pediatric ARDS. Thus, PLEAK could not make any recommendation on the optimal mode for PARDS. What you'll see on my slides, and you see on this one where it says strong agreement, amongst the PLEAK experts, the 27 experts that came together to make these recommendations, strong agreement meant that all experts were in agreement. For those recommendations on the subsequent slides of which there was not complete agreement, that was listed as weak agreement, and for each of the entities coming on the subsequent slides, I will give you the actual numbers of those who agreed versus those who disagreed. But for this recommendation that no specific mode can be recommended, there was strong agreement that we have no data. So now let's look at tidal volume. The next most frequent question is, what tidal volume should we use in pediatrics, specifically pediatric ARDS? Well, that one's a little more challenging, and actually before we focus on where I was going to highlight, I'm going to back up here a second and just talk generally, is we know in the adults, we have the ARDS Network publication back in 2000 showing that 6 ml per kilo tidal volumes improved outcomes compared to 12 ml per kilo tidal volumes. Well, in adults, we do not know anything about 5 per kilo or 8 per kilo or any other number besides 6 and 12. And in pediatrics, we do not have any definitive randomized control study to tell us what tidal volume we can use. So we have a couple of options. The first option is to rely on the adult-based data and use the 6 ml per kilo recommendation. Before we make that conclusion, right or wrong, let's now focus on the specific pediatric data. On the slide that's showing is a publication from Pediatric Critical Care Medicine in 2007. Simon Erickson in this study looked at the relationship between tidal volume and outcome. And as we see on the odds ratio, as tidal volume increased, the ratio, or the odds ratio, the likelihood of a patient dying decreased. Stated more simply, higher tidal volumes were associated with higher survival rates. The exact opposite of the findings of the Adult ARDS Network study, as I've already mentioned. Well, let's look at some additional data. These data come from Rabi Kamani's publication in Intensive Care Medicine in 2009. It's a complex slide, but these show the relationship between initial tidal volume and mortality on the top left, top right, day 1, tidal volume and mortality, bottom left, day 2, and bottom right, day 3. As we see here in this, this display of Dr. Kamani's data, we see the fact that as tidal volumes increase, mortality tends to decrease as well. Stated in more simple terms, again, these are exactly the same findings as we saw in Dr. Erickson's study on the prior slide, in which higher tidal volumes lead to higher survival. Well, as we think about that, why are we seeing this? What is really the issue here? Well, the issue here is one of an association versus cause and effect in a randomized controlled trial. So I'm going to jump ahead here to one more study before I bring this and give you my interpretation. And this is a study out of China. It's a very large study that, again, looks at the relationship of tidal volume and outcome. In this case, outcome is ventilator-free days, which is a blend of mortality and time on ventilator, or time off ventilator. And we see on the top panel that as tidal volume increases, the time of a patient off a ventilator increases as well, so outcomes improve. And those are for infants less than a year of age. And on the bottom panel, we see no relationship at all. So as you take these three studies, you got to ask yourself, what tidal volume should we use in pediatrics? Because these data seem to contradict the data provided to us from the Adult ARDS Network work. Well, the important point I'm going to make here, and I'm going to take a little aside from my slides, and I'm going to go through the difference between association and cause and effect. In this case, what we're looking at is associations. And what I'm about to say is much more easily done in a live audience versus a webinar, but I'll ask you, and obviously I can't see or hear your responses, but how many of you are coffee drinkers? And I would suspect that if you were in the room, many of you would raise your hands. Well, it is well known that coffee drinkers are more likely to die of lung cancer than non-coffee drinkers. Now, several of you are probably right now a little worried and thinking back going, I didn't know that. And you have to think about that statement. And the statement that I made is a relationship or an association between coffee drinking and lung cancer. But what I haven't given you yet is the hidden variable. And what is the hidden variable? Of course, it's smoking. Smokers are more likely to drink coffee as a habit, and thus are also more likely to develop lung cancer. Well, it's the same thing here. We see an association between higher tidal volumes and improved outcomes, but that doesn't mean that there's a cause and effect relationship. And in fact, if we go back to Rabi Kamani's publication in Intensive Care Medicine, what we see here is a clear direct relationship between tidal volume and lung injury. Those patients who had more lung injury, more severe lung injury, were more likely to have lower tidal volumes or managed with lower tidal volumes. Thus, what we see here is an association of those patients who are managed with higher tidal volumes were more likely to be less ill and thus more likely to survive. So when you bring this together in terms of tidal volume, the truth is we really do not have an answer in pediatrics because we only have prospective observational data, which again describes associations, but does not give us a cause and effect answer. So as we bring this together, the other point I want to make is that most, if not all, these patients in the studies I've just presented were managed in pressure control. Thus, if pressures are limited, again, the higher tidal volume is most likely going to be related to a better lung compliance. Additionally, a point I have not made yet is that lower tidal volumes may have been preferentially applied, intentionally applied, by those considered to be more ill. Other point, which is another uncontrolled variable, is the use of uncuffed versus cuffed endotracheal tubes and the possibility of a difference or a greater loss of tidal volume in those patients who are at a lower lung compliance. So as I bring this together again, observational studies, these are associations only and not cause and effect. Well, those are the data that and the information that PLEEC had to use or had available to them when making the recommendation that is being shown now. And in the end, the experts believed, for the most part, that in fact the adult ARDS network data of low tidal volume should be applied to children. But PLEEC was a little more general in their application and didn't give a specific number, but rather a range. So PLEEC recommends that in any ventilated pediatric patient that we should use tidal volumes in or below the physiologic range, as defined as 5 to 8 ml per kilo. Important, ideal body weight, not actual body weight. And then that tidal volume should be titrated according to the lung pathology and the patient's respiratory system compliance. So approximately 6 ml per kilo within a range of 5 ml per kilo. That was weak agreement, and as I mentioned previously, weak agreement meant it was not 100%, and in this case, 22 of 25 experts did agree with this statement. PLEEC went on to state that the tidal volume should be titrated according to disease severity, and that we should use or consider using tidal volumes as low as 3 to 6 ml per kilo, again, ideal body weight, for those with decreased respiratory compliance while maintaining closer to physiologic range tidal volumes, 5 to 8 ml per kilo, for those with better respiratory compliance. And in this case, 21 of 25 of the experts agreed. Or previously I did say 27. Two of the experts did not complete the process to voting, so there were 25 voting members. If we switch now to look at peak pressures, in the case of peak pressure, we see data that do match our expectations, and that is those with increasing peak pressures were more likely to have a higher mortality, more likely to die. In this case, these again match our expectations that those patients that were more ill with a higher risk of mortality tended to have higher peak pressures corresponding to lower compliance. So this is shown here in both Simon Eriks's study as well as Rabi Kamani's study, the exact same relationship of higher peak pressures and higher mortality. With those data, PLEEC recommended that in the absence of transpulmonary pressure measurements, which we usually do not have in pediatrics, the recommendation is that the plateau pressure should be maintained less than or equal to 28 centimeters of water, allowing for slightly higher plateau pressures, 29 to 32 centimeters of water, for those with decreased chest wall compliance. As you see, this was weak agreement, and this was actually one of the weakest agreement statements of PLEEC, with only 18 of 25 agreeing. These criteria were very much debated. I will tell you that most of the 7 who disagreed with the statement felt that the upper limit of plateau pressure should be higher than 28, that was too conservative, and should be closer to the 30 area. In either case, this is what the final recommendation became. And I would leave it to the audience to determine for themselves whether this is an appropriate recommendation or one that might be conservative. Switching now to PEEP, PLEEC recommends that moderate PEEP levels, as defined between 10 and 15 centimeters of water, should be titrated to observed oxygenation and hemodynamic responses in those with moderate to severe PARDS. Just a general statement trying to encourage clinicians to use slightly higher PEEP levels than have been traditionally employed for those with moderate to severe lung disease. PLEEC also went on to recommend higher peak levels, and this statement actually had strong uniform agreement that PEEP levels greater than 15 centimeters of water may be needed for severe ARDS, although we must consider limiting or pay attention to limiting the plateau pressure as previously described. In terms of recruitment maneuvers or sustained inflation maneuvers, those terms often used interchangeably, Palik felt that sustained inflation maneuvers cannot be recommended due to a lack of data with weak agreement at 88%. Keep in mind, this statement does not say that recruitment maneuvers or sustained inflation maneuvers should not be done. It says they cannot be recommended due to lack of data. And that is an important wording difference that we need to consider when looking at any recommendation from really any entity, the difference between cannot be recommended and should not be done. Okay, now I'm going to switch a little bit and focus on the next section here on gas exchange to look at what we should be aiming for in terms of our oxygenation and ventilation goals. And Palik has strong agreement that these goals should be based on the perceived toxicity of the ventilator support required. The key point there, especially for learners in the audience, is this perceived toxicity is subjective. It is really hard to make this an objective term, and the important point to stress is the toxicity or the perceived toxicity is likely to change within a patient over time and for the same patient as clinicians change because, again, of the subjective nature of this point. Palik did give recommendations, though, and that for mild PARDS with PEEP less than 10 centimeters of water, the saturation should generally be maintained between 92 and 97%. There we go, sorry, slide in advance. Okay, going beyond that, after optimizing PEEP, lower SpO2 levels in the range of 88 to 92% should be considered for PARDS when the PEEP exceeds 10 centimeters of water. And interestingly, despite that potentially being a controversial topic and one that's often discussed, this had uniform agreement of a target of 88 to 92% for those patients with PARDS once the PEEP level exceeds 10. What about lower saturation levels? What about those patients with even more severe lung disease? And the overall strong agreement was that there are insufficient data to recommend saturation levels lower than 88% as described on the prior slide. Does not mean that we should not, in select patients, accept lower saturation levels, especially if the perceived toxicity is high. And it's something or a topic that really needs to be discussed amongst the clinical team for each patient on an evolving basis. What was strongly felt by Palik is that when the saturation is maintained less than 92%, that there should be monitoring of the central venous saturation and monitoring of the markers of oxygen delivery. Important here, the term of monitoring central venous saturation. Palik did not specify or get into the details of how that should occur, and it specifically does not discuss whether that monitoring should be invasive or non-invasive. Invasive, obviously, through appropriately placed indwelling lines versus non-invasive using the growing approach of cerebral oximetry. There was a portion of the Palik conference that looked at and discussed and recommended respiratory monitoring, but that's beyond the scope of this 40 or so minute presentation, but I do refer the audience to the publication specific to respiratory monitoring for more details. If we now look at ventilation, the Palik experts strongly recommended that we should, as clinicians, consider permissive hypercapnia from moderate to severe PARDS to minimize the risk of ventilator-induced lung injury. terms of gas exchange goals, the recommendation, weak recommendation with 23 of 25 experts agreeing that the pH should be maintained between 7.15 and 7.30 within the lung protective strategies previously described. Again, there are insufficient data to recommend a lower pH limit, but there's no contraindication to doing so in those patients in whom the benefits appear to exceed the perceived risks. There are some clear exceptions. The exceptions listed are increased intracranial pressure, severe pulmonary hypertension, select congenital heart disease lesions, beyond, again, the scope of this presentation, hemodynamic instability, significant ventricular dysfunction, and on all my slides where exceptions are, we realized after the publication that on most of these we should also put pregnancy, as that was beyond the scope of the work that we did. Now, leaving conventional ventilation and gas exchange goals, I'm going to very briefly enter the controversial, or the growing controversial area of high-frequency oscillatory ventilation. Palik did go out on a limb and recommend that HFOV should be considered for moderate to severe ARDS in those patients in whom the plateau pressure exceeds 28 centimeters of water in the absence of clinical evidence of reduced chest wall compliance. In this case, we had 92% agreement, which was 23 of 25. And as an editorial note, I am aware that the two individuals who disagreed with this statement happened to come from the same institution. So Palik actually recommended consideration, not necessarily mandated use, but considered the use of oscillator for moderate to severe ARDS, despite being very well aware of the OSCILLATE and the OSCAR trials that I'll briefly mention in the coming slides. So with that, let's look at the OSCILLATE trial, which was the adult ARDS study that, for a large part in many units, put the oscillators in closets and really took them out of use. So let's look at OSCILLATE in a little bit of detail. First important point I want to mention about OSCILLATE is that about half the patients in both groups were septic. So we had septic patients who, as we see on the bottom part of this slide, were on significant inotropic support, and many of these patients were on multiple inotropes. So for OSCILLATE, we had a subset of sick, critically ill patients with severe ARDS who were septic, hemodynamically unstable on vasoactive agent support inotropes. So what happens when we take a patient such as this, being hemodynamically unstable and presumably intravascularly deplete, and place them on an oscillator and turn the mean airway pressure up? Well, one would expect and anticipate a poor outcome, and in fact, that is exactly what was seen. So many in the pediatric critical care world disagree with this study and feel that, in fact, the results were to be expected because a large group of patients who are oscillated probably should not have been. Now, in full transparency, there's also a group of pediatric intensivists and others who do believe these data and feel that the oscillator has not been proven and may be risky and should not be used. So the answer here is very much unknown beyond the Palik recommendation of just that expert opinion. I will take a slide from my slides, and I realize I didn't put a slide in, but I'll give you this information, that currently there is a trial that will be looking at oscillation and prone positioning and combination, and separately in all various combinations of prone supine oscillate conventional ventilation, and that study is currently under review at the NIH for funding. If funded, we may actually be able to study this in pediatric ARDS over the next several years. And that study, if you hear about it or see it anywhere, is called Prospect. So much more to come on that, hopefully. Now let's get back to the slides. I think this is an important study, and this postdates PLEEK now, and this is the Restore HFOV study. Restore was a large-scale, almost 2,500 patient study of sedation management in the pediatric critical care environment. Of those nearly 2,500 patients, a subset of those patients were oscillated. And we went back and in a post hoc type analysis using propensity scoring, looked at these patients that were oscillated. What we see on this slide, and this is a little bit of a complex slide and it's hard without pointing, but on this slide we're looking at those patients that have significant lung disease. The patients with ARDS in this case were broken down into 5 quintiles. And what we see here is that quintile 5, the sickest of the patients, are shown with the oscillator patients in red and the early oscillator patients in red, and the conventional patients and those oscillated late as rescue in blue. And we see that those patients that were on the oscillator were ventilated longer than those that were not early oscillated. If we look at quintile 4, which is now black and green, we see the exact same thing, that oscillated patients, especially early oscillated patients, were ventilated longer. Outcomes were the same. Mortality was unchanged, but length of ventilation is increased with the oscillator. So we now need to look at the conclusions of this study, and I'll read these, that in adjusted models, including important oxygenation variables, early oscillation was associated with a longer duration of mechanical ventilation. These analyses make supporting the current approach to oscillation less convincing. So the important take-home message here is really the title of this slide, which is, what is the issue? The oscillator per se, the actual oscillator and the modality of high-frequency oscillatory ventilation, or is it how we use the oscillator? And maybe we're not using the oscillator optimally by not optimizing lung volumes and not managing in an acute manner and allowing some of these patients to sit on settings much longer than necessary. More to come on that. Again, going back to the proposed PROSPECT study, PROSPECT is designed to address these concerns or these issues to really offer a new and novel approach to oscillation. So with that, unfortunately, I really can't leave you with a clear take-home message. The use of oscillation at this point is really going to be clinician and institutional dependent. Personally, here at Duke, we are relying on the PLEEK guidelines, and we are continuing to oscillate those patients in whom we believe that it has potential advantage. But our use of oscillator is somewhat down compared to prior years, especially with the introduction of other technologies and other modes, and the use of other adjunct therapies, which is where I'll switch to now. So in the last 2 sections of my talk, in the last probably about 8 minutes or so, we're going to touch on all these issues of steroids, nitric, prone, surfactant, neuromuscular blockade, and ECMO. Of course, that could be a 2-hour talk all in of itself. So I'm going to really just focus on essentially one slide for each of these topics to give you the take-home message and the key data. If we look at corticosteroid exposure, we come to this publication as shown on the slide, in which corticosteroid exposure for greater than 24 hours, as well as the cumulative dose of steroids, were associated with decreased ventilator-free days and increased length of ventilation. In summary, there was no benefit seen for the use of corticosteroids in pediatric ARDS. Having said that, these are really looking at steroids specifically for ARDS, and we know that many of these patients and many other patients are on steroids for various reasons. In terms of nitric oxide, there are several studies of which I do not have time to go through in detail, but all of these studies consistently show that nitric oxide does not improve outcome for ARDS despite short-term oxygenation benefits. There are some clear potential exceptions, and that are those patients with documented pulmonary hypertension as a potential bridge to ECMO cannulation, and then those with right ventricular failure or at least a significant dysfunction. Prone positioning now. really are offering us conflicting data. In the adult world, we have the PROCEVA trial, in which early proning for severe ARDS improved survival. In pediatrics, we have Martha Curley's study, published in JAMA in 2005, that showed no effect either way, and that study was stopped for futility at an interim analysis. It's important to mention in the pediatric study that those patients that were studied included those with both mild, moderate, and severe disease, a heterogeneous group, and of importance, the oscillator was mandated when the oxygenation index reached 15. So I think in pediatrics, we probably really do not know the answer, and that's the rationale for including prone positioning in the prospect study along with oscillation to try to answer two questions with one large study. In terms of exogenous surfactant, multiple studies that have consistently shown no benefit for exogenous surfactant administration for pediatric ARDS or adult ARDS as well. For neuromuscular blockade, in the adult world, studies shown on the slide that the use of 48 hours of neuromuscular blockade for severe ARDS improved both survival and time off the ventilator. In pediatrics, we have absolutely no data, and at this point we need to either rely on the adult-based data and use neuromuscular blockade for the first 48 hours or so of ARDS, or take a different strategy, which is often discussed and considered, which is one of not paralyzing, trying to keep our patients more awake and more interactive. That debate will again go on for quite some time until we have some more definitive data in the pediatric environment, some more discussion on that to come. So I would refer the audience to this, the publications out of the PLEEC supplemental material, again, Peds Critical Care 2015, which looks at the pulmonary-specific ancillary treatments for pediatric ARDS and covers, in what I just went through in just about 5 minutes, all of this material in a great deal of detail. But I will offer you, in closure to this section, the conclusions of this article, and that is that overall, the routine use of surfactant, inhaled nitric oxide, glucocorticoids, prone positioning, endotracheal suctioning, and chest physiotherapy cannot be recommended. Inhaled nitric oxide should only be used for patients with documented pulmonary hypertension and or right ventricular failure. Prone positioning may be considered in patients with severe PARDS, and most importantly, that future studies are definitely warranted to establish the role, if any, of these ancillary treatment modalities in pediatric ARDS. Okay, lastly, let's come to ECMO. When all else fails, maybe, or sooner than that, maybe. This schematic is one that I like to go through for ECMO and ARDS, and you can actually use this for almost any modality, for almost any disease, and that's a benefit of risk versus benefit. So first I'm going to show here in yellow is ECMO. The horizontal axis is severity of lung disease. The left side is mild disease. The right side is severe disease. In those patients with mild disease, the risk of ECMO clearly exceeds benefit. But as the patient gets sicker and lung disease worsens, the risks are still there, but the benefits start increasing, and thus that ratio starts changing towards the use of ECMO. Well, on the same slide, if we now graph lung protective ventilation, when patients' lungs are not very ill, the risks are quite low these days. But as the patient becomes more ill and the lung disease worsens, we see that risk-benefit ratio swing as ventilator-induced lung injury and secondary complications arise. So what we need to consider with ECMO is that crossing point, that sweet spot in which we have the optimal balance of risk and benefit. From a schematic slide in a talk like this is easy. In real life, finding that spot is quite challenging. And day to day, week to week, year to year now, I do believe that crossing point is moving slightly more leftward as ECMO becomes simpler, safer, and more easily done. Along those lines, here's a picture of a traditional ECMO pump from years ago, and here's ECMO of today, smaller, more concise, and in fact, mobile. And I'm just going to do a couple of slides here talking about mobile or ambulatory ECMO to show the fact that ECMO is very different today than it was many years ago. Here's a picture of two pictures of two patients who have severe lung injury and are both on ECMO and actually ambulating throughout the ICU and often throughout our children's hospital. We do have several studies that have shown specifically to the pre-lung transplant population where more of these data are now available that ambulatory ECMO, walking ECMO, reduces costs, reduces length of ventilation, reduces length of stay post-transplant, and actually improves survival. In the area of non-pre-transplant ECMO or more traditional ECMO for ARDS, these patients are a little more of a challenge, and we have not quite as much data as we do for the pre-transplant population because these patients are much more challenging, and walking and ambulating such a patient has only been done over the last couple of years. These patients present real challenges because when they wake up and you start moving them, they're not used to being awake and moving with severe lung injury, and they become very tachypnic, dyspneic. They have a real sense of air hunger, and they become very anxious. But through a lot of support from both the families as well as the staff, it is in fact possible to walk such patients and have patients as shown here who have acute ARDS up and about on ECMO. So in conclusion, let me just offer some summary thoughts before we get into about 10 minutes of question and answer. PLEEC is really an initial step. Hopefully it's setting the stage for further work. We need to validate the definition of pediatric ARDS. We need study-specific recommendations, things where we have real hard data, and we need long-term follow-up that we don't have today. Widespread acceptance of these recommendations and utilization will help forward the field beyond really its infancy as we get both more experience but also more data and more feedback and more discussion on the PLEEC recommendations. Further study is clearly needed in everything that I have presented this afternoon. And we got to keep in mind that these recommendations are likely to change over time and perhaps significantly as more data are obtained. So where are we? We have a pediatric-specific definition for ARDS. We have conventional ventilation and gas exchange guidelines, which focus on lung protective ventilation with titration of settings based on lung pathophysiology. For oscillation, the jury is still out. For adjunct therapies, for the most part, there's no proven benefit for PARDS, although several of the therapies, as I mentioned, may offer potential beneficial effects for some of our patients. And ECMO is smaller, simpler, safer, mobile, and we may need to really consider potentially moving towards ECMO a little bit earlier to avoid the toxicities of more conventional therapies. And lastly, I'll repeat the same statement, and I'll encourage many of you to please get more involved with research and try to study many of these really important topics so we can continue to improve the care that we provide to our patients and their families. With that, I will conclude and thank you for your time and your attention and your participation, and I will turn it back over to Shauna to help lead the Q&A session.
Thank you so much. A lot of great questions over in the Q&A section, so I'll just jump right on it. One of the first questions we received was, why was the oxygen index chosen over the PF ratio for the scoring of PARDS?
That is a great question, and that is a question that is often asked and often discussed and honestly often debated. And it's frequently debated between adult adult-based practitioners and pediatric-based practitioners. The strong feeling in pediatrics and the very strong feeling by PLEEC is that the oxygenation index is a better parameter to use because it includes the mean airway pressure, it includes the ventilatory support being provided. A good clinician can change the PF ratio on a patient with lung injury quite significantly by simply adjusting the PEEP on the ventilator. So many of us, and personally, feel that the PF ratio, although often used, very simple to use, often employed in definitions, is not quite as good as the oxygenation index, again, because the real issue with oxygenation is mean lung volume, and mean lung volume is mean airway pressure, and you have to include mean airway pressure in consideration.
Thank you so much. Another question we received was about the various parameters and measurements, lung compliance, PEEP, or delta P versus mortality. Has anyone tried to correlate any of those specific features?
So unfortunately, in pediatrics, we just don't have the definitive data. We don't have studies looking at those relationships. There's some adult-based data, but for peds, hopefully we'll be able to do that over time. And again, the prospect study that I mentioned previously with the oscillator proning combination study is going to look at all of those variables to look at ventilator, and the primary endpoint will be ventilator-free days, but we're going to look at that relationship between ventilator support, modality, and real outcomes. So I'm hopeful that data are coming. There's growing interest in studying this in pediatrics, and hopefully by the time there's a future webinar on this, we will have better data.
Thank you. And again, another plot out there for engaging in research as we need that information. So another question, and this is comparing the peds and adults. When we're optimizing our PEEP, do we follow the same algorithm for optimizing PEEP that we do in adults, that we do in children, or is that different?
Great. Now, these are all really great questions. These are all the questions that PLEEC really wrestled with, and people designing the studies that I've talked about and others really wrestle with. So how do you optimize PEEP? At this point, largely, we really do need to rely on some of the adult-based approaches, the approaches of PEEP FiO2 tables, and also the approach of PEEP titration, looking at that optimal balance of oxygenation, hemodynamics, lung compliance, pressure volume loops, in combination. The one thing that we do have to really keep in mind, though, before just going out and blindly applying adult-based data and algorithms to children is the obvious. Our smaller children are just that, smaller. And there is a concern about taking the adult ARDS network PEEP FiO2 tables and applying them to a small child or a baby, that some of the PEEP values at the high end of that curve are quite significant. So in children, we don't have specific PEEP FiO2 tables. This exact point was discussed in detail in the design of the prospect trial I mentioned. And the reason I say it here is there was a large group of clinicians who provided input into the design of this study who truly felt that the high end of the NIH ARDS network PEEP FiO2 tables were too aggressive, and in fact, what we ended up doing was truncating the top portion of the curve to not go up to the PEEP levels recommended. And right now I'd have to look back at our charts where we cap off, but instead of going up to about 24 on the adult studies, we capped off about 16 to 18, and don't quote me on the exact number, I would have to review that, but we did cap off a little bit lower because of that concern.
So earlier in the presentation, you were very clear to state that the optimal mode for ventilation was whatever the unit and the practitioners felt most comfortable with, that they could utilize most appropriately. One of our participants wonders if NAVA could be considered as an option for PARDS patients.
Right. So the one thing, I don't recall if I said it exactly this way, but I do want to clarify the point earlier compared to what you just said, Shauna, is that the optimal mode is the mode that practitioners are most comfortable with, that units are comfortable with, and that that the clinicians feel are as applicable to the patient. And the key parameter there is always, of course, considering the patient's pathophysiology, which is probably the underlying the question that was asked is, what about NAVA? Personally, I do not have a lot of experience with NAVA, so I don't want to go into too much detail because it would be unfair to do so. But I will say that the real niche for NAVA is patient ventilator synchrony. So that is really what NAVA is designed for, is to optimize the interaction between diaphragmatic activity, the patient's desire or wish to have a breath at that moment, with the ventilator responding. So in terms of PARDS or ARDS or lung injury in general, one would think that if there's patient ventilator dysynchrony problems, that NAVA could be a reasonable approach to use. On the other hand, if a patient is synchronized well with the ventilator, then NAVA doesn't really offer a benefit in pathophysiology over alternative modes. And at that point, again, comes back down to clinician preference of whether they feel the specific pathophysiology of that patient warrants improved patient ventilator synchrony. Unfortunately, I can't get into any more detail with that. Again, not using NAVA frequently, and also, it's going to change based on the details of the individual patient more than the generalities of this discussion.
Thank you very much, Dr. Cheifetz. And one more question. Is there a role for epoprostenol in the management of PARDS?
Oh, how about maybe? Really don't have a lot of definitive data at all in terms of PLEEC. It was kind of mentioned, and I don't remember if the supporting article actually included that in the final publication or not, but in general that went a little bit beyond the scope of what we were trying to do, because we truly not only do we have no data, but honestly we didn't have a lot of expert experience to even come out with a true expert opinion on that. So unfortunately, the answer to that is I don't know.
And again, another plug for more research. Dr. Cheifetz, thank you so much for joining us today.
Great, thanks. And if anyone in the audience has specific questions, want to reach out to me, assuming my slide is still being shown on your screens, my email's there. Please feel free to do so, and I appreciate your attention, participation, and look forward to seeing many of you at the ARC Congress this fall. Thanks, Shauna, for inviting me, and it's been a pleasure to be here.
Thank you so much. Please join us for our next webcast on Wednesday, July 12, for a review of case studies in non-invasive ventilation with Brady Scott, and again on Tuesday, July 25th, for a presentation focused on cardiopulmonary exercise testing with Carl Mottram. Thank you for joining us, and have a great day.
Thank you so much, and a big thank you to Ira for sharing his expertise today, and thank you all for your interesting questions. In just a moment, you will see a Submit Credit button on your screen. If you are an individual who is registered for this program, you will need to go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This does conclude today's presentation. You may exit out of the window, and we hope you have a wonderful afternoon.